Hello, good afternoon, good morning, good evening, everyone who's joining. Thank you for your patience, whilst I'm connecting with Dr. Smikle, who is the medical director of Laurel Fertility Care, who are a fantastic clinic based in California, San Francisco. Thank you to those who are joining again. We have a super amount of information to give you and talk about today, which is all around PCOS for PCOS Awareness Month, which is September. We have some brilliant questions that people were just asking now, and we're going to be talking about symptoms, whether most people display symptoms, what that means for your fertility. People were asking about ovulation, about miscarriage. So let's get Dr. Smikle on here and we can start. Nice to see everyone today. Hopefully this will work. A few technical issues today. I'm not sure what's going on. Let's see. Yes, we're connected. Hello,
Finally,
Dr.
finally.
Smikle.
Hi, wonderful. I am so sorry for all the glitches for this afternoon. So
No
it's
problem at all. We've got you here now, and we're delighted to be speaking to you today. So thank you for your time. I've just
no,
given
not a problem at all.
I've just given a brief introduction to yourself as Medical Director of Laurel Fertility Care. Please could you explain to anyone who's joining a bit more about yourself and the clinic? And then I've just mentioned that for PCOS Awareness Month, we're talking about symptoms, what that means for fertility, treatment options, etc. So please do introduce yourself to any new people joining.
Okay, so my name is Dr. Smikle. I'm the medical director of Laurel Fertility Care. We have offices here in San Francisco and the Bay Area, and we've been managing and helping patients build their families for more than 15 years now. We deal with a lot of patients with a variety of diseases, including polycystic ovarian syndrome. And so, we're very well versed in terms of helping not only to understand, but also some of the measures that we would actually help patients to kind of go through just to improve their outcome and improve their measures in terms of conceiving.
Mm-hmm.
So that's it.
And I just touched on the fact that September is PCOS Awareness Month.
Mm-hmm.
What percentage of women suffer from PCOS, and is that a large percentage of the patients that you see?
Well, I think the one thing to realize is that it does depend on the population. So therefore, in different groups will end up having different, basically percentage of patients with PCO. Overall, the common thought is just that it accomplishes about between 5 and 12, 15% of patients who are going through fertility treatment. A lot broader patients will have that. Many of those may not be going through fertility treatment. You'll end up having patients who are, say, part of the Indian population who may end up having more PCO type features. There are a couple of groups in South America who also actually have a higher percentage of their women who have PCO. So it's something that is relatively common and commonly treated. In our practice, we see probably about, say, 5 to 10% of our patients with PCO who are going through treatment. So it's relatively common, and it's something that we're very well versed in terms of managing and dealing.
Mm-hmm.
The key thing to understand is just that it's a syndrome, it's not a disease. So therefore, you'll end up having a lot of patients who may end up having some mild versus some other forms of that. And that's something to kind of just educate them about the process, but also about, things that they can do to manage some of the symptoms they may have.
I'm sorry, I haven't asked you, but for those who don't know, please could you explain what PCOS stands for and what it is? And I know there's lots of different terms for it, aren't there?
Right. So basically, PCOS is polycystic ovarian syndrome. Basically, it was originally thought of as Stein-Leventhal syndrome from the individuals who basically first understood it, a long time ago. And basically, when it was first described, it was described in patients who were overweight, had irregular cycles, had some sort of, hair growth disorder. So you may end up having either a lot more hair growth in areas that are actually not commonly known, or basically you end up having thinner the hair due to a lot of the male type hormones. You might have women who have male pattern type baldness because of the severity of the disease. So it does come in a very a large plethora of symptoms in different individuals. The important thing is just that, especially now that we know more about it and that patients are actually finding out earlier, you'll end up having not just patients who are overweight, but thin women with PCO. They may not have all the same features, but they'll end up having something changing in either their menstrual disorders, where they may not be having skipping periods for months on end, but they'll still have some irregularity and they'll have some changes in terms of their ability to conceive.
Mm-hmm.
So although the diagnosis is a lot easier to see now, and we see in a larger group of patients, the management is relatively the same.
Okay, thank you for explaining that. And what do typical PCOS symptoms look like?
So, as I said, commonly you might see someone who has irregular cycles. So, therefore, most women will end up having cycles between, say, 25 and 35 days on average, most around 30. Women with PCO may end up having changes where they'll end up having their periods once every 2 months, every 3 months. They can actually extend even to once a year without management. That does have its own set of symptoms that we have to kind of basically contend with, because women who have very irregular cycles end up having some other issues that we have to basically manage for their own health and well-being. So it's important to kind of know just in terms of where on that spectrum you are. The other things you might see are, basically increased facial hair, sometimes hair around the nipples, hair along the midline. You may end up having, basically, as we talked about, thinning of the hair because of the male type hormone. Acne is one of the common things. Things you can see in the lab or from blood tests, you might actually see elevations in FSH to LH ratio. You might actually see, some changes in glucose or insulin regulation. So those are the common things that you'll see in some patients. So it's a format, it's a syndrome, it's something that you have to piece together just to kind of basically treat each person as an individual.
Mm-hmm, absolutely. And not everyone displays these symptoms, do they? Because
exactly.
You've just written a brilliant article for us, which we will link up in the bio, which is all about debunking PCOS symptoms and the myths that come with it. So, people find it, and we've asked our community, and I'm sure you've had patients say the same thing, that people assume that they should have, I don't know, facial hair or whatever
Right.
it might be that people associate with PCOS.
Well, the common thing is just that, especially since, people start looking at this a lot earlier, you'll end up having a lot fewer women who are going to be, overweight as you expected before. You may end up having women who are, basically having a little bit elevated BMI, but still not in the morbidly obese region that you'd expect, or actually was initially associated with the syndrome. And especially in those women who are thinner, you may end up having not as much facial, no facial hair, or not as much acne, but they still fall within the spectrum of patients with PCO. And especially if you're looking at, an ultrasound, that's where you commonly see similarities in terms of those patients, because you'll still see that, the multiple follicles within the ovary, the high antral count, if you will. And then you'll see the laboratory corresponding findings you'll find in terms of high AMH levels and other things in terms of insulin resistance as well in some patients.
And there are different sort of acronym, different names for it, aren't there? Some people say Pcos as well?
Pcos, PCOS, some people used to call it PCOD, Stein-Leventhal syndrome. So therefore, there's a number of different syndrome associated with it. In really severe forms, you might hear the acronym HARIAN, where basically you have really, really high levels of male type hormones, and you'll end up having, hirsutism, you'll end up having the insulin resistance, and you'll end up having a lot of other parts that actually fit within that syndrome as well. So it does vary in terms of the symptomatology, but all these are going to basically be relegated into the same measures, if you will, in terms of this common phenotype of PCOS.
Mm-hmm. Absolutely. And what would be your recommendation for patients that you see at Laurel Fertility Care? What's your advice for managing symptoms?
I think the big part in terms of basically considering what to do comes down to what your goals are. I think, patients who are actively trying to get pregnant, then one of the things you might actually have to do is to, remove or reduce the need to control either the weight or the hair growth or hair loss or the acne, and then focus on getting pregnant, because getting pregnant is going to be one thing that basically is going to be getting you to ovulate consistently, getting you to end up having improvement in terms of the quality of the egg you ovulate, just so you'll be able to get and maintain a pregnancy. Patients with PCO who are basically not as well managed may end up having a higher chance of miscarriages. So, working with those patients would basically work towards that goal in managing and improving that parameter. And then dealing with hair, dealing with acne, dealing with a lot of the other changes after the delivery. For those patients who are not interested in terms of getting pregnant, at least right now, then you're focusing on those things in terms of focusing on using measures, using medicines to kind of control the weight or the hair, excess hair, or the acne, just so that they'll end up having better management of those symptoms. For those individuals who have really irregular cycles, making those cycles more regular is going to be important, because the women with PCO, if left untreated and you're having really irregular cycles, they're more prone towards developing endometrial hyperplasia or, in very long-term endometrial cancer as well. It's well managed, it's well diagnosed, but it's something that we have to kind of manage to make sure that those young patients don't progress to something as, in that situation.
Mm-hmm. Thank you for expanding on that. We had a couple of questions before, which I'd love to ask you if that's okay. The first was PCOS and miscarriage. Is there any connection there?
There is an association between PCOS and miscarriage. One association was just that in patient with that really elevated LH to FSH ratio, there's a hyperandrogenism that's there, that it may just be that there's not a proper amount of the progesterone support to the placenta. Those patients may also have a higher risk or higher chance of having the insulin dysregulation, meaning you can't metabolize glucose as well. So those patients are going to be more prone towards miscarriage. So using measures to promote and maintain the placenta and maintaining that support is going to be important. Managing the blood sugar associated with that is going to be important. One patient, commonly patients may hear about using metformin with in a treatment, whether you're trying to get pregnant or through pregnancy. And that's actually a good way in trying to managing those symptoms. Patients also hear about using a lot of I'd say the dietary supplements, myo-inositol, as aids in terms of improving PCO. Using a PCO diet, basically that'll actually be one that is lower in carbohydrates. And so that all helps to kind of manage the underlying issues that may contribute to or be associated with higher miscarriages.
Mm-hmm. PCOS and trying to ovulate. This lady said she's been trying for almost a year. Every month ovulation is a different day. So what's your advice to people who are in that situation? Is it to go and see a fertility specialist?
Well, no, I think many times, patient because PCOS is a common disorder, many general practice providers can actually help to manage at least the early phases and the easier managed situations. So they don't always have to come to see someone like me. Many times they'll end up here, but sometimes you can actually have some of that treatment start with your local provider. That includes using oral medicines like either Clomid, clomiphene citrate, or letrozole, which is Femara. And those are going to basically help to break that cycle, if you will, to allow you to ovulate. The issue with PCO is that you may actually start developing a follicle, but it never gets big enough to where you'll end up having that breakthrough to ovulate. Right. Using those agents will help to basically make you ovulate more consistently, and that's where basically getting pregnant is going to be. And then for those patients who are resistant to that, then they'll end up coming to see someone like me to help them to kind of do things more precisely and further elaborate on that.
Makes sense. And what if patients don't have standard symptoms? How do you test for it or test for that?
So a lot of it is history. So basically getting, they may not end up having that irregular cycles, especially if they're very thin. And then doing an ultrasound, doing blood tests to see, and looking at family history as well, because, not just the female within that family, but male will have male pattern baldness. So therefore it will give you that association. So it's getting that family history. In ultrasound, seeing that ring-like appearance in the ovary is one of the things that we commonly use. In Europe, much more than in the United States, they rely on ultrasound as the primary means for diagnosing PCOS. But it's putting all those things into context and managing the symptoms and managing the patient's ovulation that's going to be important.
And what are the chances of getting pregnant with PCOS?
Well, patients with PCOS can actually, once you start them to ovulate more consistently, have a relatively good and a fair chance of getting pregnant. Because of the risk of miscarriage, you'll end up having to support pregnancies more often. But, patients can actually still do very well. And not everyone will actually have to go on to some other, more advanced assisted reproduction. They can do fairly well. They can do very well with, just letrozole or letrozole using, metformin as an adjunct, and also using progesterone as a support for the pregnancy. So, those are the common things.
Okay.
A small percentage of those patients will also have some thyroid disorders as well. So you'll end up having to manage that symptom as an addition. So therefore, you'll improve their chances for success.
So I know this is hard to answer because every patient is different. If you see a patient who might be who has PCOS and you've done the tests that you just mentioned to confirm that, what would be your next steps? Would it be starting with something like Clomid to see whether they could try and conceive naturally? And at what point would you then say, okay, maybe let's look at doing IUI or IVF?
Well, I think a lot of it comes down to conversations with patients about, what their goals are in terms of building their family. For someone who basically just wants one child and is basically okay, and it also depends on the patient's age, because unfortunately PCOS also extends into, later adulthood as well. So if you're young and you have the time and you want to try less aggressive measures, going through and using either Clomid, clomiphene citrate, or letrozole as the initial measure is an important start, and trying that for 1 or 2, 3 ovulatory cycles. And what I mean by that is just that you might try the first dose that's not successful. You have to increase the dose until you ovulate. Once you have that ovulatory cycle, then you'll have to monitor and make sure they're, ovulating consistently. But also, especially in terms of using letrozole, making sure that you don't have the secondary effect of having the impact on the endometrial lining. Because oftentimes we'll see a patient who gets clomiphene for 3 months from their doctor, they're taking consistently, there's no monitoring done, and the patient is going to end up ovulating every time, but with a very thin endometrial lining. And therefore you'll end up basically having, you're changing one problem for another, where you'll end up ovulating, but not have the means to have the embryo implant. So therefore, that's the other issue we have to deal with. And sometimes changing the medicines. I'm sorry?
What would you do in that situation to improve
Sometimes it's changing the medicines, going from Clomid to clomiphene citrate to letrozole, or stopping for a month because the half-life of clomiphene is about, say, 6 weeks, then switching to that, or just basically using the injectable form. Oftentimes, we'll end up breaking that cycle. So it's not, patients with the thin lining can always improve with basically some sort of assessment or treatment. You can't use Clomid and estrogens to do that because it's not going to have that same effect. But sometimes it's just backing off, starting over, and starting a different process to kind of basically get through that.
Okay. Ashley has said she's 32, she has PCOS and abnormally high AMH. Is it worth waiting to try for a family, or should she start trying sooner rather than later, in your opinion?
I think the key thing is, in terms of answering the question, it depends on how many kids does she want and the time frame she wants her family. Realizing that if she's 32, has PCOS, and if she's not ovulating every month, by the time she starts making the decision she wants to have her family, then she'll end up she's starting behind the curve, if you will. So it's important to kind of basically make a decision when she wants to start, and then very proactively making the decision in terms of going through measures, taking the medicine she needs to use, make sure her partner is actually evaluated to make sure that he's not contributing anything to the faction, and then planning things accordingly. Because yes, she can actually can succeed without really a lot of intervention, but it's something she does have to be proactive about.
Okay, that's really good advice. And for someone who has PCOS, when you do an egg retrieval, do they tend to have more eggs? Oh, sorry, yeah, more eggs, more follicles?
Yes, they do. So typically, patients with PCO will also have what we call an elevated AMH, anti-Mullerian hormone. They have a lot more eggs. And so you have to be really careful in terms of how to manage the stimulation of those patients. The goal in an IVF cycle is typically to get someplace between, say, 10 to 20 eggs. Getting more eggs, it sounds great, but it's not necessarily the best thing. You may actually impact egg quality depending on how the cycle is managed. It's not to say that patients with a high number of eggs are always going to have poor quality. It's just that you'll end up having some changes that you'll need to do to basically manage those cycles. So the important part is, at least what we do, is to tailor the patient's goal in terms of what family size they want to basically predicting and planning for the number of eggs we're trying to retrieve. And the goal being to still get within that 15 to 20 number of eggs to build their families.
Mm-hmm.
More than that, they're going to be more prone towards basically being overstimulated and all the consequences that go along with that. And then, patients with PCO are much, much more prone towards having the ovarian hyperstimulation syndrome, where you'll end up having a lot more fluid gain, a lot more discomfort, and end up having to have other measures to manage those symptoms.
And why are people with PCOS more prone to suffering from OHSS?
They have more eggs.
Right.
OHSS is primarily related to eggs, so therefore, especially if you've never been stimulated before, it's hard to kind of predict what's the exact dose of medicines to use for that stimulation. We'll use a lot of the hormone levels, your age, your AMH level, the number of androgen follicles you have in terms of trying to plan for that stimulation. But even those measures may end up undershooting the treatment plan, and you'll end up with 50 or 60 eggs. That's a lot, and so therefore that's going to cause you to end up having a lot more bloating, a lot more discomfort, and it makes it harder to sort of manage. We still have other measures to try to kind of reduce those symptoms if those patients are still going through the cycle. We can use measures in terms of reducing how much medicine they're taking, or use other supplements to basically reduce the symptoms, when we're triggering and when we're doing the retrieval itself. Still, the more eggs you have, the more likely that there is for the ovary to get overstimulated and the fluid leaks from the ovary, and all the sequelae from those stimulation processes.
Because you're right, the first thing that people probably think is, that's great, isn't it, that I've got lots more eggs?
Yes, everyone always wants a lot more. It's always something that we're fraught with basically making a decision in terms of, sometimes more is not better. If you have diminished reserve, more is always better, but that means we're going from, say, 5 to 10, or from 10 to 15. We're not going from 5 to 50, and that's a big difference.
Absolutely. And what is the sort of likelihood, what are the sort of success rates for people having fertility treatment who suffer from PCOS?
Well, believe it or not, the success rates are very similar. If you can manage a lot of the underlying situations that may arise, the glucose intolerance, sometimes diabetes, sometimes the thyroid hormones associated with it. The pregnancy rates and delivery rates with PCO are relatively similar. The good thing is that many of those patients will have more choices because they'll end up having more eggs, more embryos, and if you're doing genetic testing on those embryos, may end up having more embryos to transfer. But if you can kind of basically manage a lot of the underlying symptoms, the chance of delivery is going to be, or the rate for delivery is going to be the same, somebody compared without PCOS. The key thing is that many times it may take a longer time to get through to the transfer. It's very likely that you're not going to have a fresh transfer because the hormones are just going to be too high. And even with successive transfers, it may take a while to get to that right regimen, if you will. But those patients still do well in terms of basically being able to deliver.
Mm-hmm.
So again, it may be a little bit tweaking the regimen, may be a harder thing to manage, but they still do very well overall. You have more eggs, you have more choices.
It's really good to hear. And for someone who might be trying for a second child,
Mhm.
um, and you've maybe had a child, is your body likely to know what to do and sort of reset, if you like, after you've had a baby? Does that sort
So
of reduce the
the,
chance
the,
of having problems with
the
ovulation?
question you're asking and the myth that's there is that let's say you have PCO and you successfully conceive on your own, is it likely that you're going to end up having another successful pregnancy
Mm-hmm.
without really any intervention? And the unfortunate thing is the answer is no. Because you were fortunate in terms of hitting an ovulatory window once, doesn't mean you'll end up having the same, expectation. And many times those patients weren't really planning to get pregnant. They got pregnant inadvertently, and then they're presuming that they'll have the same experience the second time. In the second planned pregnancy, especially in patients who are not ovulating, it is starting over, and I think that's the hardest part. The big part, though, and the advantage in terms of someone who goes through assisted reproduction is that for those patients who do have embryos frozen, then the diagnosis and the timing is actually not really going to be germane because you can plan when you're going to do the transfer.
That's really true. Yeah. We've had some great questions today. Thank you very much. And
Mm-hmm.
Dr. Smikle for answering all of them. Really, really appreciate it. For anyone who has just joined and didn't hear, Dr. Smikle and the team have written a brilliant article about symptoms and debunking symptoms, PCOS symptoms, especially as it's PCOS Awareness Month now, September, and I'm going to link the article in the bio, so please do go and read it. It's really excellent advice and information elaborating on what we've discussed today, and also all the details to contact the team. We love the team at Laurel Fertility Care, and as I mentioned, you're a boutique clinic with several clinics in California and the Bay Area, so please do get in touch with Dr. Smikle and the team, who will be able to help you with personalized plans and consultation, etc. Is there anything else that you want to add, Dr. Smikle, whilst we're on this theme?
Well, I think the biggest thing to add is just that, for patients with PCO, or at least considering or evaluating whether you have PCO, to first be proactive and, seek out advice in terms of managing the symptoms. And when you're ready to start your family, really, really start earlier than you'd expect, only because it may take a bit more time. But, with measures, especially with those patients, you can still have success. And that's important to realize. So it's not quite as bad as you'd imagine it to be, even as you get older.
Well, that's a positive note to finish on, so thank you so much. And I am really looking forward to meeting you finally in person next month.
We're looking forward to that as well. It's been,
Yeah,
I know that we spent a lot of time in terms of these communications. So, and thank you, and
absolutely.
thank your audience for actually allowing us to basically participate. So we're
Absolutely.
looking
I
forward to
think
that as well.
we're going to be going live on TikTok, so follow us both there. And this is at the end of October, so really look forward to doing that in person. It will be great.
That'll be great. That'll be great.
Wonderful. Thanks, everyone. Speak to you soon.
Well,
And do check out the article in our bio. Thank
all
you.
right. Take care
Bye-bye.
now. Bye
Bye.
bye.